Hi there. Welcome to ICHOM's interview with Fractal EDM, and particularly with Rubén Rojas. Rubén, please would you introduce yourself and also Fractal EDM? Can you tell us a bit about yourself and what Fractal do?
Thank you, Ben. Thank you for the invitation also to this interview. Yes, my name is Rubén Rojas. I'm health economist and also business administrator. I did maybe the half of my career doing corporate finance and strategy. And now my role in Fractal EDM is to be the Chief Executive Officer. I have done this role for the past 7 years. And we have some offices in Europe and US recently this year, and also Latin America, where we started 7 years ago only working in Chile. And our aim of our work is to incorporate the economic perspective into value-based healthcare delivery, among other activities that has a strong economic perspective, in order to having a good calculation of the changes that we are putting into the system in the perspective from the payer or the provider.
Fantastic, thank you. And am I right in saying that the EDM stands for economic decision making?
Modeling, yes. Yes, we started like a company that made all the economic models, like Markov models for cost effectiveness analysis, dynamic modeling for infectious and transmission diseases, and then we move to more forecasting models for the future. For instance, how many dialysis centers should we have this country or this state or this city, regarding all the prevalence, incidence, mortality, and natural evolution of some diseases. So we started like a modeling company. That's why EDM stands in our name.
Excellent, thank you. Now, you are part of the ICHOM conference this year. You've been an ICHOM partner for a little while. Can you tell us a little bit about how value-based healthcare plays a role within Fractal?
Yeah, we are very committed to value-based healthcare. We are very convinced that in the long term, the problem of the health systems about their sustainability should be driven by a shift of incentives, that we have now some incentives on volume, some incentives on retained costs, should be shifted in many ways to find the profit for the players in a different way. So that's we are committed to value-based healthcare in the way that, from the economic perspective, you have to unveil the numbers behind those incentives. So as we do modeling, economic and financial crossover, our work aims to do that, to find those numbers and to say to the provider or to the payer, okay, this should be your new configuration of profit. This will be your new configuration of revenue. And it's how all comes together. And that is the role of value-based healthcare also.
I don't want to put words in your mouth, Rubén, but do you think it's integral to effective delivery of value-based healthcare that there is an understanding of the economic financial implications in implementation, in launching an initiative in this area?
Yes, in my experience, when you are trying to convince some senior management to do this, maybe the first questions that arise from them is how will change my structure of revenue or my profit or my costs. So I know that value-based healthcare has a lot of things to add to the table, like outcomes measurement, very good monitoring, clinical measurement, and everything. But the questions from the senior management remains the same, like how this will impact to my actual activity, how long it will take to shift the investments in this unit, like an integrated practice unit, how long it will take to move my profit in the long term. So I think that it should be add to the equation of value also.
Thank you. So just to follow on from that, do you find that your clients typically are coming to you with a decision kind of already there that they want to implement a value-based healthcare program, and now they want to look at the finance, or are they still wanting to do the financial planning first before they want to commit?
My experience, they want to understand the dynamics of this, because they have a lot of years working in some way, and you will tell them, so we need to make some changes to the delivery process, where you now will be measured, the cost will be measured in another way, and you will have to make some investments, like setting up an integrated practice unit, for instance. And when you talk about the advantages of doing that, you mentioned like you will have outcomes measurement for your patient, clinical process and structure measurement for the process, and also patient-reported outcomes. That is a key role. But I think that in their brain, it's always the money thing, like the financial thing, how much it would be cost, how much more I have to spend in this unit. Should I need another software for the measurement? Because I do not have integration, for instance. So you now will have to invest in some tool for integrating all the stuff together. So even though the part of the clinical benefit and the patient-centered benefit is critical for them, there is always a concern about the financial side also.
Yeah. Thank you. Now, may I ask a little bit more about the organizations that you work with? I'm particularly thinking about working directly with healthcare providers on the one hand, versus working with perhaps payer organizations or regulatory organizations. What sort of organizations are coming to you for support, first of all? And secondly, do you ever see a tension between what, say, a payer might be looking for and what a provider might be looking for? Or do they work in harmony?
Yeah. Well, good question, Ben. The first natural client for us is the closed systems, where they need to be providers on one side and payers in other side. They have the both roles. So they are concerned in the long-term health of their patients under care, but also in this financial sustainability. Mm-hmm. So this is our first natural client when you say we are going to shift the organization in order to have better care, more protection to the people under care, and in the long term, a very good result because we are going to prevent hard consequences. That's our first natural client. The second, when you have a provider that has many payers, is different because it always have some business-driven decisions. So, for instance, in a provider that has a free election of payers, like in USA, they need to build some good cases. For instance, shoulder surgery. In my provision side, you have a very fast surgery with this cost and this medical leave after that. So you build a package, and all the value-based healthcare centers in a very narrow site or space of the like maybe Professor Kaplan will say the clinical cycle of the care is only from the pre-surgery to the rehabilitation, only that part. And the providers tell us to build the financial case to then offering that package to the payers and make better business between them. So in that way, the thing flows. When you are going to a provider and you will ask them to do a more preventive care in order to avoid harder consequences, sometimes we have been asked about, but this is going to have a lower volume for me because the higher volume is the harder consequences. So that maybe is the hardest part, because in this friction zone between the volume and the cost reduction, it's like some perverse incentives between them. So it's very hard to align.
That is a great challenge in certain health systems. You're right, but let me just go back to your point about an enclosed sort of payer-provider system, and you mentioned that those kind of organisations would be looking, on the one hand, for the long-term health and well-being of a patient, but also the management of costs in a sustainable way. That's where everyone wants to be, but lots of organisations struggle to make that balance. What do you think is one of the biggest challenges for value-based healthcare as a whole, from that perspective of balancing long-term costs with long-term patient outcomes?
Yeah, it's. I think that it's like an onion with some layers, because you first will need to convince to the senior management that this could change the way that the system works in the future. After that, you should, what I have done in the past is to go with them to the ICHOM conferences, to them touch how it is this, and how is the conversation, the dynamics, and the frameworks behind that. After that, you need to trust, to shift that convinced story for the senior management to the medical teams, because not everyone in the medical sector, I'm economist, not doctor, but not everyone wants to be measured in their performance. So when you say, okay, this Dr. A has many more referrals that Dr. B in the same site, they don't want to be measured. So you need to train them in order to have a good interpretation of that measurement, that is not going against them. It's going to improve the operational efficiency and the outcomes of the whole unit. Otherwise, you will have a friction on the medical team, and it will be very hard to overcome. And then to implement value-based healthcare in our organization, you need to have the medical team on your side, because otherwise it wouldn't work. So I think that in the organizational structure, that will be the main challenges, the strategy team and also the medical team.
Yeah. So I hear what you're saying. It's not just the financial implications, it's the cultural implications as well.
Yes, because they have done the work in silos for years, maybe from the beginning. So it's very hard to work in other way. In our first experience, we had a lot of friction from the medical team. So we overcome that only with training, because otherwise you will not do that.
Yeah. Excellent. Thank you. Now, you mentioned the conference, which is a great excuse for the next question. You're one of our conference sponsors this year, and as indeed you were last year. Could you tell us a bit about why you're excited about the ICHOM conference 2023?
Yeah, we are very passionate about the ICHOM approach, which is hands-on. This is not a theoretical congress or you must do this thing in this way. No, in the ICHOM conference, we talk to other people which have the same challenges that you find in your implementation. So the hands-on approach of ICHOM is our preferred way to learn. One thing is to say, as I mentioned before, to say what has to be done, and other completely different thing is to do that and to know by yourself. So I think that ICHOM conference is very well balanced between the theoretical frameworks, but also the results on the real life experience of implementing value-based healthcare.
Great, thank you. And we very much look forward to catching up with you there and hope that you'll be able to make some great connections. My final question really is just, what advice would you give for organizations who are looking to implement the value-based healthcare program, whether it's using ICHOM's model or anything else? As you mentioned earlier, they'll all have concerns about, is this going to cost them lots of extra money? Will they lose lots of patients? Will it cause disruption with my payer organizations? So really, what's your piece of advice, Rubén, for organizations who want to do a better job for their patients?
Wow, hard question also, but maybe the best thing to know or to trespass or to advise them is to think in your own experiences when you have someone, maybe you yourself or someone from your family has a very big disease, and then you capture that the problem is not about the disease, it's not about the response of the drug. It's a very multifactorial and multidimensional program. And the first thing you need to do that, to capture all the different dimensions on a health program, on a health problem, or in a disease, is to find out the meanings for the patient of those consequences. And there arise the ICHOM standard sets, where you have some dimensions for the payer, for the provider, but almost all of them are from the patient and for their families. I always remember that in one case we were doing an economic assessment of a lung cancer drug, and it was not cost effective. But after doing the calculations, we present the ICHOM set of lung cancer, and some dimensions that appeared on that standard set was from the patient perspective, how many days I will spend on the hospital in my last days. And the other thing was, I want to die in my home, my family.
Yeah.
And that changed the picture in 1 second. So there is so many things beyond the clinical and the technology side of the health technologies or the diseases that has not been captured by the generic instruments like EQ5D, SF36. The ICHOM standard set captures everything. So, and that for me is the magic, the first magic that happens when you say, okay, we are going to hear to listen the patient and to take into account that their perspectives. So this is now what is important for everyone, not only for the doctors or only for the payment side. So I think that this is the core of the healthcare delivery. So this is my first suggestions, is to change the perspective from what tells the doctor to what tells the patient, what is important for them. And after that, you can do a lot of work on the IPUs and the delivery and the optimization and the financial and everything. But everything, I think, that starts by capturing the different dimensions of diseases. And I think that the perfect work that you have done is to capture every single disease and how they affect in many ways to the patients that even the doctors don't see that until they have the standard set on their face.
Great. Rubén, thank you so much. It's been great talking to you. We look forward to seeing you at the conference. Thank you very much for your time.
Thank you. Thank you, Ben. Thank you for inviting me.